We welcome you to Webinar 7, How to Assess Your Local Market's Prospects for Payment Reform with Suzanne Del Banco and Mark Gagne, presented by the National Association of Health Underwriters Education Foundation. We hope you enjoyed the program and we thank you for joining us today. A PDF copy of today's presentation has been made available to you to print or download. You may access this document by clicking the Resource tab on the left side of your screen. You're encouraged to submit questions at any time throughout the broadcast by selecting the Forum tab on the left side of your screen. Simply type your email address and your question and click Submit. Ms. Del Banco and Mr. Gagne will answer questions at the end of the program, and questions not addressed within our available time may be answered by way of a post-conference email. At this time, I'm happy to introduce Janet Trautwein, NAHU Executive Vice President and CEO, and NAHU Education Foundation President. Here is Ms. Trautwein.
Thank you. Well, welcome to all of you who are on the call today, and I hope that you've been able to enjoy the other calls in this series. This is a series sponsored by the NAHU Education Foundation. It's entitled The New Healthcare Landscape, and this series today is a part of a 10-part series that goes through November. Today's live webinar and all future webinars, again, are free and are located on the NAHU Education Foundation's website. So if you've missed the past, we encourage you to go back and view all of them, and we would love to hear your feedback. It's my pleasure to introduce the presenters for today's session. Suzanne Del Banco is the Executive Director of Catalyst for Payment Reform, an independent nonprofit corporation working on behalf of large healthcare purchasers to catalyze improvements to how we pay for health services and to promote better and higher value care in the United States. In addition to her duties at CPR, Suzanne serves on the coordinating committee of the Measures Application Partnership for the U.S. Department of Health and Human Services, the Healthcare Incentives Improvement Institute Board, and participates in the Healthcare Executives Leadership Network. Mark Gagne is a co-owner and Chief Innovative Officer of Borislow Insurance. Located in the greater Boston area, Borislow Insurance is highly regarded as a leading employee benefits brokerage and consulting firm, serving over 350 corporate and 2,000 individual clients and more than 100,000 members in 35 states across the country. Mark has more than 25 years of experience in the healthcare industry and is a pioneer in the use of consumer-driven health and wellness plans used to lower healthcare costs and to improve health and well-being. Mark is passionate about the power of consumerism, health, and wellness to transform the workplace. And now I'd like to turn it over to Mark and Suzanne.
Thank you, Janet. Appreciate being here. Suzanne, hello. Look forward to our 7th webinar together. So I thought, as we have done in other webinars, to kind of frame our discussion for this afternoon and just use the following talking points to kind of get your mind going in the right direction before we jump into the content of our talk this afternoon. I think it's been said before, but I'll say it again. If you've seen one healthcare market, you've seen one healthcare market. I've lived in 3 different geographic areas: Boston, where I call home now, the Mid-Atlantic area in Washington, D.C., and Chicagoland area, and I can tell you that this statement is actually very true. What works in one location does not work in another, and I think this afternoon's discussion would be very helpful for us to wrap our minds around that. The demand for changes in payment, delivery, and provider consolidation are definitely reshaping healthcare markets, and there are different forms of payment reform, as we've talked about for the first 6 series of webinars, in terms of what providers and insurers are attempting to do to try and rein in runaway healthcare costs. If you work with large self-funded employers, multi-site employers, I believe that this presentation will speak to you. If you're in the small end of the group market, this presentation may not mean as much to you relative to helping your clients, but it certainly will help with conversations that you're having with decision makers as you're growing your business. There are tools that can help educate you on the dynamics of markets and how provider contracts and health plans are working together so you can better assist your clients. We would encourage you to take advantage of those tools. Helping you understand the structures of the market and helping your clients understand what works will help you assess what types of payment reform are prevalent in those markets that you work in and ultimately help you add more value to your client relationship. So with that being said, I'll turn it over to Suzanne to kick us off.
Thank you so much, Mark. And I'll just start by saying that when I started the work with Catalyst for Payment Reform, my job would have been a lot easier if we could just say there's a one-size-fits-all solution for payment reform and blank is what it is. But unfortunately, we're really never going to have a one-size-fits-all solution because, as Mark was just starting to say, every market is different. And not to mention, I'll just add on top of that, just to be honest, that we also don't really know yet exactly what payment reform method works best in every context. We have a lot to learn just generally about which payment reforms work. And then there's the added complexity of the context in which you're trying to implement them and whether or not they're going to succeed based on all kinds of local dynamics. And that's really what this whole webinar is going to be about today. And, fortunately, I think there are ways that we can educate ourselves about a particular market to help us be more thoughtful about what kind of payment reforms we want to push for there, even if we don't have all the answers. There are ways of getting ourselves better equipped to think about what the potential opportunities are, what the successes could be, and frankly, what the potential unintended negative consequences could be if we were to implement a certain type of reform in a certain market. So that's, what we'll be talking about today. And in particular, we have worked for a few years at CPR to develop what we call our market assessment tool. And so we're going to go in depth about the components that it entails. And this is something that you can gain access to through the CPR website. And again, it's really about having a methodical process for thinking through all the dynamics in a market before moving forward with payment reform. So I look forward to covering all these components with you today, and I'm sure there'll be a lot of questions, so we'll be sure to allow for time for that. So moving on, let me just make sure we get to the next slide. Sorry about that. Moving on, what I wanted to share with you are a little bit more background on what contributes to a particular market's dynamics. When we thought about all the different aspects of a given healthcare environment, we felt like the most influential factors were going to be the people who are working from different perspectives to try to make the marketplace work, or in some cases, frankly, to try to make the marketplace advantageous or profitable from their perspective, depending on how you see it. And the three major players who really influence those dynamics are the payers, and this is a term that I have to define for a moment here because we all use so many different terms to mean the same thing. I'm talking about the health insurers, the carriers, the health plans, whatever you like to call the companies, like since Mark is in Massachusetts, Blue Cross Blue Shield of Massachusetts, who are, for the most part, negotiating payment methods, payment amounts, and processing claims. So their role in a marketplace obviously can be very influential. Then there's the employer, and in particular the self-insured employer who acts like its own payer in many ways, although they often hire a third-party administrator to do the administrative functions of buying health care. But what they want in a given marketplace, what they want for their employees can have some real impact on a market. And then also, of course, the healthcare providers. How organized are they? How dominant are they? How willing are they to take on new things and new approaches to being paid? And then, of course, given I just mentioned the dominance of a particular provider being a factor, how consolidated the market is in different ways. Is there a dominant payer? Is there a lot of competition among payers? Is there a dominant provider? Or is there a lot of competition among providers, et cetera? How organized are the employers? Are they working together in a single voice to try to affect change? Or are they very fractured and working independently? All of that can have an impact on what kind of reforms might be able to get passed through and what kind of reforms are likely to succeed. And then, of course, because so many of the aspects of changing how we pay for care, and in particular making it related in some way to the quality of care, is dependent on our ability efficiently to measure, to process claims, to group together different services of care into a single payment, things like that. The proliferation of health information technology is also very, very important. We've had automated processes for paying claims for quite a long time, but we haven't had that automation or easy access to data on the quality side as much. And that's really important if part of what we're trying to do is move to a more value-oriented payment system where a performance on quality factors in some way into payment. So these are the kinds of dynamics that we're talking about that can vary from one market to the next. So in addition to the market dynamics, I guess I want to make some observations about some of the characteristics we've noticed in markets that might have an impact on what kinds of payment reforms could be implemented or could succeed. So one thing we found is that larger, more integrated, sophisticated provider systems are generally in a better position to accept new forms of payment. Chances are they have good coordination and communication across providers, or better than average, I guess I would say. They may have already experimented to some degree, even if just internally, with changing how the money trickles through all the providers. They may already have participated, let's say, in a Medicare accountable care organization experiment or program. So the larger sophisticated provider systems are likely to be in a better position to accept new forms of payment. Consolidated markets, depending on who's consolidated and whether they're sort of fat and happy with the status quo, some players in a consolidated market may be resistant to change. If a dominant provider is making quite a nice margin as things are today, why would they want to change? Why would they be welcoming with open arms something that might put them more at financial risk, for example? So there, you'll find leadership plays a big role, and sometimes you just have wonderful leaders at the heads of these organizations who say, it's the right thing, it's the future, let's do it. But a large dominant system can have the ability also to thwart efforts at reform by saying no thanks. And the other thing I would say, we don't see it very often at all. But when employers are organized and working together in a market in a way, of course, that's within the legal bounds of what they're allowed to do jointly, let's say they have a common quality improvement and measurement and reporting initiative, that can have a big influence on the market. But in most markets across the country, we don't see that. We do see business coalitions of various types that are organized, but often they're just for educational or networking purposes, not so much to change the dynamics of the market. But there are exceptions, and where those exceptions exist, the dynamics can be very different. I think Mark and I have both made the point that there is no one-size-fits-all solution. What works really well in one market would be cause for celebration, but it might not be cause for replication, given the requirements that might be needed. For example, if you have an integrated delivery system where there's great communication across hospitals and community providers, you might find a system willing to take on, for example, a global payment or even some kind of shared savings program where they all work together to meet a budget and get to share in any savings across the board. In a market where you don't have that kind of provider, individual practices, small group practices might not be in a position to do that. So understanding these market dynamics can allow employers and other healthcare purchasers and payers to implement targeted payment reform strategies. And that's what the discussion today is really about, preparing you to think through with your customers. So I'm going to make a little bit of a switch here now to talking about a tool that we've developed that can help people to do this. And again, I want to be really clear that this tool is, think of it like, I don't know if any of you follow Mark Bittman in the New York Times. Sometimes he's a food writer, and sometimes he puts out recipes that don't give you any quantities, don't give you very precise instructions. It just kind of says, try some pasta with roasted peppers and roasted garlic and dry fried pine nuts, and toss it together with olive oil, salt, and pepper, and eat. And he doesn't give you a whole lot of specifics about how many pine nuts, how many peppers, how long you should roast them for, what kind of pasta you should use. But you get the general idea and think, that could be something I could create for dinner. So the market assessment tool is more along those lines. It's giving you some methodical steps to think through. It is, we're actually conducting our 6th market assessment right now. over the last few years. We've kind of done a couple a year. We've perfected our process as we've gone, but it really is more, of a slow you down, take a moment to pause and think in a variety of ways to get you to be thoughtful. It's not necessarily an algorithm that will pop out the exact answer, and because, like I said before, there is no exact answer. But what it does is it helps create a comprehensive inventory of market characteristics that may impact healthcare delivery and payment reforms. And the goal really is to create a shared understanding of the stakeholders in the market about where things stand and where things could progress to, given the attitudes, the experience, the dynamics in the marketplace. And I think we've already talked about some of the dynamics. The other thing I haven't mentioned in talking about those dynamics is obviously local regulations or state laws also can have an impact. And so that's another aspect that sometimes needs to be taken into consideration. Certain states have prohibited the use of telehealth, for example, or there might be a state that doesn't allow for gain sharing among hospitals and physicians. There might be a state that doesn't allow for capitation to be paid to physician groups or something like that. So obviously the local regulations and laws matter in terms of what your opportunities are. And what I'm going to walk through going forward now are the different aspects of how you can paint a complete picture of what's going on in a given market. And you need some structural data, just sort of some basic statistics about the market that help you understand how it's built, the relative size of things, et cetera. And then really what's important is to hear from people in the market who know it intimately, but from all different perspectives, and start figuring out what kind of common themes emerge. And what's nice about going through this process, and this is something that honestly each of you could probably spend a few days, you schedule a handful of calls with people from different aspects of the healthcare system and the market, and you go into a bunch of questions with them, and by the time you're done, you might have insights into the market that even though you've lived there for a long time, you've worked there for a long time, you just didn't realize, because sometimes attitudes, willingness, all that kind of stuff doesn't come out unless you ask. And that's why we have found this to be sometimes a very powerful process. So as I mentioned, we have some experience doing this. We did a few pilots to start in Columbus, Ohio, Long Beach, California, and Memphis, Tennessee. We then were hired to do assessments in Minneapolis, St. Paul, and Grand Rapids. And I can tell you, each of these markets was unique, different from each other, although I think, again, the common theme in all of these markets is that the employer-purchaser side of things is not very organized. And I think, like I said, one of the most valuable things those who asked us to do these assessments got from it was to have a real 360-degree view from all the different stakeholders of the market, to have a shared understanding of where things stand, where things could go, what kind of willingness there is to experiment, and that sort of thing. As I mentioned, we continue to try to refine our process, what kind of data we think are necessary, how to gather that data, how to streamline the process, make it more efficient. And the other piece of this is that we tried, when we started this, we were kind of amazed that no one had ever really tried to come up with a way of creating a typology for different markets. This is a market type A because the providers are dominant, but the purchasers aren't organized and the plans have a lot of competition. Market type B might look like something different. No one had ever come up with that, much less any kind of pairing between the type of market and the type of payment reform that might work, or what kind of payment reform should be tried first, second, and third. And so as we were developing this whole approach, we actually interviewed, I think I did 35 interviews with a variety of experts about different types of markets and what kinds of payment reform, in their view, would work best and what types to stay away from. And it was really fascinating. And, after the first 5 or 6 interviews, I thought, oh, gosh, we're never going to get agreement here. But the more I did, we actually charted it out. You could see some real accordance across these experts, some of whom were academics, some of whom were literally implementing reforms on the ground, really a diverse group of people. you could start seeing some very strong convergence about what types of reforms would work in certain types of markets. But we want to continue to bring in that expert opinion, especially because, honestly, it's 3 years later now since I did those interviews. There's more experience under people's belts, and there's more that we can continue to learn.
Suzanne, when you say employer purchasers are not organized, can you describe what you mean by that?
Yeah, so I talked about this a little bit a few minutes ago, which is that you can find a few markets across the country where employers have worked together, for example, through the Pacific Business Group on Health in California, through the Maine Health Management Coalition in Portland, Maine, where they have come together and said, what is wrong with our healthcare system locally? What do we want to do to improve it? How can we, without, violating antitrust laws, we're not going to get into price fixing or something, but how can we as a group start making it very clear what the employer is looking for in the market and start even measuring and reporting publicly on things that matter to us? So there have been everything from, quality measurement and reporting programs, registries that are developed around a specific procedure, to look at outcomes. There are efforts to, pool data, of course, into all payer claims databases. And a lot of these things where they have happened have been employer-led. So employers, by working together, can really affect a market. And like I said earlier, unfortunately, it's more rare than common.
Thank you.
Mm-hmm. So the market assessment tool is divided into a bunch of components, and I'll walk through them each one by one in a moment. So there's a user guide that orients people who want to use it. There's a multi-stakeholder online survey, and in fact, that's the phase that we're in right now in the market assessment we're conducting. There is an interview guide meant to be used with key stakeholders, key informants in the market. There is a checklist for the kinds of structural data you would want to gather, and most of those data are either freely available or for purchase for very minimal amounts from sources like the Book of Lists. And then we have created an eight type market typology. So you remember I was talking a minute ago about market type A, type B. We have basically come up with a way of dividing markets that I'll share with you. And then a comprehensive list of payment reform options and recommendations by market type, as well as a user agreement. We've put a lot of investment into creating this tool. We're happy for people to use it in sort of one-off nonprofit purposes, but obviously we're not that eager for a big consulting firm to take it and start using our intellectual property to build a big business that we could be in like we are in right now. So the user guide, which hopefully is written in simple language, will guide users on how to conduct the assessment through a step-by-step process, to learn how to identify what type of market you're dealing with, and to help you identify which payment reform option might work best for that market type. As I mentioned, there's an online survey that we've developed. This is a SurveyMonkey survey, pretty straightforward stuff that's pretty easy and fast for people to fill out. And it's meant to be sent to all the different stakeholders in the market. So we have a unique survey for healthcare purchasers or employers. We have one for payers or health plans. We have one for healthcare providers, one for consumers, and one for regulators. And all these online surveys can be done within about 10 minutes, but they ask critical questions about the history of the market, the operational readiness for payment reform, and the willingness to engage in reforms going forward. And participation is really critical. It's not really meant to be a scientific quantitative study, but to really get a good broad view of the market, you probably want about 50 people completing this survey. And it's not always easy to get, especially in a very small market, but where it's possible, it can give you a very robust view of how people perceive the market, what kind of things have been tried before, and what might be possible going forward. Another thing that's very helpful, like I said, is to kind of size up the market statistically or quantitatively. And there aren't that many statistics that you need to do that. we think it's helpful to understand the size of the population, the insurance coverage for that population, who the biggest players are on the provider side and what kind of market share they have, and also how consolidated the market is in terms of the providers. There's a standard economic index called the Herfindahl-Hirschman Index, HHI Index as it's known, and it's pretty easy to calculate. And then also what payers or health plans are in the market and what's their market share. Same with employers. Is there any huge employer that could influence things? Are there a few huge employers that working together could influence things? I have experience from the days when I used to run the Leapfrog group of having an incredible success in the Seattle market because of a combination of some very large purchasers there, some famous companies that are headquartered there who are all willing to work together to encourage hospitals, in that case, to publicly report on their quality and safety practices. So sometimes knowing, exactly how many big purchasers there are, what percent of the market they represent can help you understand the dynamics. And again, many of you probably kind of know this stuff already, but sometimes having the numbers straight in front of you helps give you insights that you might not have had before.
Suzanne,
and then,
was there any thought given to including, since you're from Massachusetts, you probably know this, but our Attorney General actually did commission 3 different studies of the market and specifically focusing on the disparity of unit cost. Was there any thought process to adding that type of measure in this type of analysis?
Yeah, that would be ideal. The tough thing is that Massachusetts is one of the only states where that data are available easily. It will become available in other states where they're assembling all payer claims databases, and there are a handful of those that are well on their way to being able to produce that kind of thing. But we tried to come up with a checklist here that was doable for most people.
Great.
Massachusetts is lucky in that the information that they've gathered and been able to really, frankly, require has provided insights into the market that are unparalleled.
Great.
And
Thank you.
I've been lucky enough to work with some of the people producing those reports, and they are in a unique position. So as I mentioned, the online survey is very helpful to kind of give a superficial, perception of the market that really can give good insights. But sometimes you know what it's like. You have an hour with someone who really is in the know, and you get to ask them all kinds of questions about the dynamics, really how they're feeling about things and what they're willing to do going forward. And that can be incredibly, deep in terms of sort of the texture and understanding of the market. So we recommend, talking to a variety of stakeholders, from the physicians to the hospitals, health systems, the payers, consumer representatives, and people who work in state government, either as regulators or running state programs, to understand, what they see as where the market's been and where it could go. Because sometimes there are programs underway that haven't been publicly announced yet that you'll catch wind of. It really can provide some very helpful insights without a huge investment of time. So all that stuff I think is pretty straightforward. So we've talked about an online survey, we've talked about structural data, and we've talked about in-depth interviews. Here's where some of CPR's creative work comes into play, and I'm sure that people on this phone who are very experienced could critique it quite well, and that's great. Any feedback you guys want to give us, we'd love, because we consider this sort of a living approach that is going to evolve and change over time as we learn more. So what we try to do in creating a market type identifier is to help the user translate the survey findings, interviews, and data to determine what type of market they're in. And essentially what we decided, as I kind of mentioned at the beginning, is that healthcare providers, employers and other healthcare purchasers, and payers or health plans are the 3 forces in the market that we think determine the type most. Now, we know that this is an overly simplistic view. We know that there are going to be other influences. We know that we're leaving things out here. But if you were going to have something that was, 16 dimensions, all of our brains would hurt. We wouldn't be able to use it. So we tried to really boil it down into the most essential elements. And so what you're looking at here is across the top, you see healthcare providers. And there's 2 columns, one where we say that in the market, healthcare providers are not particularly shaping the market. And on the right, on the left, they are shaping the market. On the right, they are not particularly shaping the market. So, in a market like Boston, let's say, since we're talking about Massachusetts, we know that the healthcare providers have a big influence on the market. So we would probably be in the left column. Then when it comes to healthcare purchasers on the left side, you can see that there's also two sections. One where they are not shaping the market, that's the bottom two rows, and where they are shaping the market, that's the top two rows. And like I said, in most parts of the country, you're going to find yourself residing somewhere in the bottom two rows. Now, in addition, as an added layer, if let's say you're in a market like Massachusetts, where I know the employers and purchasers do not play a very big role, then you look to see whether or not the health plans are shaping the market or not. And that's what HP stands for. So HP minus means they're not shaping the market, and HP plus means they are. And I would say in Massachusetts, and Mark, you can correct me if I'm wrong, that Blue Cross Blue Shield of Massachusetts has a big influence on the market. And so I think in many cases the market is shaped by the health plans. There are a lot of smaller community plans there that are one-offs. They're not part of big national carriers that also can help shape the market by providing alternatives. And I know, for example, the state purchaser who buys for employees of the state utilizes some of those smaller health plans because they're willing to put programs into place that the big payer is not. Mark, do you want to comment on the Massachusetts example?
Yeah, I think your comment about health plans shaping the market like Blue Cross is an accurate one, but I'd also say it's the dominant, partners as an example, the dominant healthcare system. I think It's a combination of plans and providers collaborating where the employers, as an example, employers in Chicagoland have a lot more influence, even though that place in Northwestern is a big gorilla. Large self-funded employers do have an ability to impact the marketplace. But in Boston, I would also say one of the things that we are seeing, I'm curious for your reaction on this, we are seeing the lines blur, not entirely, but we're seeing the lines blur between health plans and providers. So we're seeing a lot more partnerships and collaboration. So it's getting harder to tell over time who the insurer is and who the provider is. So I'm curious about your thought process about that emerging trend.
Well, I think this is a fascinating trend and one that we're all going to want to watch. I got a lot of phone calls about the proposed mergers between some of the very large health plans that are, being discussed. And one of the things I said is, I think it's bad for competition because employers, big national employers who need to rely on the big national carriers because they want to have a uniform experience for their population and less administrative hassle, are going to have fewer choices. And I think that's a bad thing because I think choice always stimulates innovation, and competition is a good thing when it comes to the carriers. On the other hand, there's a whole new market, I think, of competition that's coming from a different place, which is that as providers take on more and more risk, they are essentially becoming payers in their own way. They're taking on the risk that a health plan or a health insurer usually does. And at some point, I think there are going to be more and more offerings for employers to buy healthcare directly from a provider system rather than go through a third-party administrator. And of course, there will be upstart health insurers too and health plans and other entrants into the market as the market continues to evolve. So I think, it's going to be something that continues to change. But I think you're right that there are all kinds of collaboration that are happening and all kinds of evolving roles. And I think some of the health insurers are worried because they don't know what their future is and they don't know, where they're going to be able to insert themselves and be valuable in the marketplace.
Yeah, I think to your point, another trend that we see happening is health insurers, frankly, if they step back from it, right? Providers didn't necessarily go to school to learn how to be risk managers. That's what insurers do. So I think there is absolutely some commonplace that they can partner together. I think what we're seeing here with our health plans is they're now starting to message themselves as health services organizations as opposed to underwriters or managers of risk, which I find it's a subtle change, but it's one that I think speaks to the comment you just made about where their place going to be, 3, 4, 5 years from now.
Yeah, I think it's going to be really fascinating. I'm trying to remember when it was. I guess it was in the early 2000s when there were a whole bunch of health insurance mergers, and it's kind of been, a little bit calmer and quieter since then, but now it's a whole other round, and some people say it's in response to the consolidation of healthcare providers. Other people say it's in response to opportunities in Medicare Advantage and the exchanges. I mean, there's lots of theories as to why it's happening. But I think the market's going to look very different in 5 years, as you were saying.
Yep, totally agree.
So this is our attempt at coming up with a way of typing markets so that if we wanted to have this shared nomenclature, and talking about, well, in this kind of market, this sort of payment reform works, we can refer to this typology as a way to have a shared language. And like I said, it is very much a work in progress. If anyone has feedback, they think we're missing really critical elements, we did test out this typology with many different people and have improved it over time, but I welcome further improvement. And so whether it's in the Q&A today or in other communications, let me know if you have other ideas.
Suzanne, one idea that's off the top of my head, since you've done so much work in the transparency area, I think, making some kind of correlation between states that have adopted, more rigorous transparency requirements and then their impact on your construct. I think that would be an interesting. Your map shows that not many states have embraced that so far. So your data set, your data set may be limited, but at the end of the day, I do think that's an important data element to include in your analysis of the market.
Yeah, I couldn't agree more. I think that would be a really good improvement, and there is such variation, so it would be a good factor in terms of helping to differentiate one market from another. Good suggestion. So obviously, if you're going to try to figure out how to pair a type of market with a type of payment reform, you want to have sort of a inventory to check against in terms of the payment options there are out there in the marketplace right now. And we organized this in a way that made sense to us. There's lots of different ways to organize it, sort of similar to the typology. I welcome feedback. But what I found to be very helpful, at least for the employers that we work with, is to talk about the different types of payment reform that are out there as being upside only for providers. So those payment methods where a provider ideally can stand to earn more if they perform well on quality or meeting cost targets and things like that. There are downside only payment methods where if a provider, for example, performs a procedure that is thought to be unnecessary or harmful, there might be no payment for that. So an example that I've mentioned in these webinars before would be in South Carolina, where the Medicaid program and the Blues plan have stopped paying for early elective deliveries. And that, has had the goal of trying to reduce the number of early elective deliveries because they lead to poor health outcomes for the mother and the baby. And then two-sided risk, which is where there's both a potential upside for a provider as well as a potential downside. And that's, I think, where the market will be evolving to. When you think about, for example, a bundled payment, let's say the bundled payment is designed to make them a provider slightly better off than they were under fee-for-service, but if they overspend, they have to eat the costs. Or in an accountable care organization payment model, there might be an opportunity for shared savings, but also the opportunity for financial losses if there's overspending. So there's all kinds of examples of these types of payment reforms. But as you can imagine, if you are thinking about a particular market and particular players with particular dynamics, some of these just general categories are going to play better than others. So if you're in a market where the providers are really dominant and frankly don't have to change the thing they're doing if they don't want to because there's nowhere else to go for someone who wants to purchase health care, probably you need to start with a carrot and not a stick, because they'd be more likely to agree to reforms that had a potential upside than ones where there's a potential downside, since, frankly, they can just say no. So that's the kind of thing. In markets where there's a lot of competition among providers and where some want to show their leadership and gain more volume in business as a result of that, they might be really willing to take on a two-sided risk arrangement of some kind. So that's why coming up with a sense of the market dynamics can be very helpful in thinking through the payment options. And in many cases, in fact, in most cases, anywhere there's new payment methods implemented, usually the path is that it's the first step is to have upside only and then to migrate toward two-sided risk. The exception being in some of these programs where there's non-payment, whether for early elective deliveries or hospital-acquired infections or things like that, where really the payers want to come down with a hammer and say, look, we don't want to pay for care that shouldn't be happening at all. So that would be, I think, the exception there. Let me just pause there and see, Mark, if you want to add anything before I get into the last two categories. Okay. So the last two categories are not about payment options, really, even though we listed them here as payment options, but they are important levers and tools that employers and purchasers have in a market. The fourth category listed here is consumer shift, and forgive the sort of awkward terminology, but the idea is really to play around with benefit design, and I know this is something you all have great expertise in. Play around with benefit design to shift where consumers seek care to direct them toward the higher value healthcare providers. So whether it is a reference pricing program where an employer sets what they consider to be the proper and reasonable price for a service like a screening colonoscopy, and the idea is that if consumers want to go somewhere more expensive, they will have to pay the difference, and that's rewarding providers who are charging a reasonable price and encouraging providers with higher prices to bring them down. Or it's a tiered network of some kind where there's lower cost sharing when consumers go to high-value providers judged, based on quality and costs and prices, versus when they go to poor-value providers. So there's a lot that can be done on the benefit design side, and even also to make, I think, add on to Mark's point, even just with transparency. I mean, we know that making information public on quality and cost doesn't necessarily in and of itself change consumer behavior, but sometimes it can be an absolutely necessary ingredient to be able to implement some of these benefit design changes.
Yeah, Suzanne, I'd just like to add in the area of consumer shift to higher value providers, two things that I'm starting to see as emerging trends is the impact of what's called concierge medicine or membership-based medicine. A client of mine had a primary care physician for the last 25 years is no longer taking insurance contracts and now charging his patient base a membership fee of $3,000 per individual, $2,000 for an individual, $3,000 for a family, and $1,000 per family member just to have access to that primary care physician. So the impact of now providers, we don't want to be part of a large provider system. We don't want to be consolidated. We also don't want to deal with the hassles of trying to get paid for what they do. That is an emerging trend we're starting to see a lot of. In addition to that, the second area is domestic medical tourism. Now, domestic medical tourism could be as simply as somebody from Springfield, Mass, in the western part of the state coming to Boston for care, or it could be somebody here in Boston going out to Oklahoma City, as an example, getting surgery at the Oklahoma Surgery Center because the cost is half or a third of what it would be here in Boston. So I think we're starting to see a lot more creativity in those areas, and I'm curious for your view on those two emerging trends.
Yeah, that's right. And I think in tough markets where the competition is really limited, these are the kinds of things that employers, especially the big employers I work with, are beginning to explore, whether it's developing a Centers of Excellence program where they identify which providers really do have good value for a certain service and, getting rid of any cost-sharing requirements or any that they can for the consumer so that the consumer, is more motivated to select those providers. Using telehealth as a way to control utilization of an overpriced healthcare system. There is some, not a lot, of direct contracting and, as you called it, sort of domestic medical tourism that some of these employers are setting up. So I think when the going gets tough, you got to get creative, and that's what we're seeing some of the big purchasers do. And some stories have filtered through to me where in a given market a provider put out an RFP for Centers of Excellence outside of the market, and the providers in the market said, hey, wait a minute, let's renegotiate because we don't want to lose our people to elsewhere. Let's find a way to continue to work together.
Competition is a wonderful thing, as I know we both agree.
Sometimes things need to be shaken up a bit. And the last thing I wanted to say here is, there's a lot that can be done in the marketplace to try to make the healthcare system work better. But there are times when things really are just completely out of whack, and there is a role and a place for government to step in. And, one, I think, great example is what Mark was describing in Massachusetts of these reports that the Attorney General did. They were able to subpoena providers and others to give information to them that they formerly hadn't had access to really help them understand the dynamics of the market better, to make sure that there was adequate competition and that and to figure out how else the market could function better. So there are times and places where government does have a role, and while employers who we work with are not in a position to legislate things, they can, as needed, advocate for some changes. And so this is really here to indicate that, if all else fails, government is there, and in some cases can make some market corrections that might help the market function better and frankly more like a real market, which healthcare in many cases is not. Anything you want to add on that, Mark? I can imagine that you're thinking.
No, I'm good. I just, I think under the construct of the ACA, the level of variability and flexibility has been significantly narrowed for purchasers. So that's kind of inherent in the construct of the design. I just think, government does have a role to play, as you're suggesting. I just think in some cases we've really hamstrung the purchasers from being more flexible and creative in their local markets.
Yeah, on the other hand, I think we have a whole bunch of new products we wouldn't have had without them. And, it has influenced the commercial market in a really interesting way. And I guess it varies from state to state, but certainly in California, there are offerings now that employers can take advantage of that didn't used to exist before the exchange came in. Yep. But anyway, so this really what this list is trying to do is say there's lots of different payment methods and different types of payment methods, but don't forget that there's two other levers. One is benefit design and transparency, and the other is, we're absolutely needed to have the government play a role. So then you can imagine if you go back to the 8-cell chart we were looking at a moment ago on the market typology, and this list here of options you have, then the question is, how do you draw from this list and figure out which are the best options for the market that you're in? And again, remember the market is going to be defined by the market-shaping capabilities of health plans, of employers and other healthcare purchasers, and of the healthcare providers. And that the structural data and the stakeholder input can help you really, determine which market type you're in. And I have found, at least through the 5 we've completed, that there really wasn't a whole lot of debate. By the time you get all that information in front of you, it's pretty obvious which market type you're in. And then we have gathered, like I said, through interviews with 35 experts of all different types, and really some of the leading thinkers on payment in the marketplace, some of the leading evaluators, some people who've really gotten their feet wet in implementing reforms, which types of reform work best in which type of market. And that's something that CPR can help with as a resource. So it's a really fun and interesting process. I don't want people to walk away, though, thinking that there's only one way to do this. When CPR does a market assessment, as we're doing right now, we get pretty into it, and it's a fair amount of labor, takes some time, takes some resources, and that may not be the position that everybody is in. But I think if you were to take a look at the tool, it could spark some thinking in your mind about the kinds of things you might want to explore and investigate a little bit to understand your market even better than you already do today. As I mentioned, you could take a shortcut. You could gather the structural data about the market from sources you probably already have access to, and then you could do some key informant interviews, using our structured interview guide, and walk away having probably a lot of the information and insight that you could get without doing the full-on process. And so I want you, to take away from this that there are flexible ways to kind of use the method that we've come up with. Like I said, we don't think it's fully baked or not something that should continue to evolve. So if you are interested in taking a look, we do have a very simple user agreement that we ask people to sign. We are happy to provide further orientation to any of you who are interested. So you can reach out to us or through NAHU to connect with us, and we're happy to do that. And like I said, you could do your own modified version, or if you had, really vested interest in doing this thoroughly, and you had a bunch of, let's say, employers who wanted it done and some resources to bring to bear, CPR is available, to do this. I don't want this to sound like a marketing call, but given our experience here, I just want everyone to know, as a nonprofit, we have a vested interest in helping payment reform advance as effectively as possible, and that's really where, we are coming from in developing this tool and trying to perfect it and trying to get more and more experience with it. We learn so much every time we do one of these things, and if we didn't have to, pay the bills, I would practically say we would pay for the opportunity, because it is such a great opportunity to go in depth in different markets, seeing reform efforts at work or the lack thereof, and trying to understand, what's going to be needed going forward, because it helps us understand the big picture far better than we could without it.
And Suzanne, I wanted to applaud your organization for, trying to take a crack at something that's very challenging. And as someone who works with large multi-site employers, one of the things we always sit around the table talking to those organizations about is the markets that they're in. So they might be headquartered here in Massachusetts, but they've got 8 markets across the country, and then having the ability to look at that from a strategic standpoint and say, okay, well, is it a one-size-fits-all construct across the country, regardless of the dynamics of the market, or would it be more valuable for us to sit and kind of overview for that client? Well, here are the market dynamics. Here are the types of markets that you're working with, and maybe for some employer clients that they're working with all the constructs that you've come up with. So I think this is a great tool that we could use to help with that conversation. As it relates to leaning on your organization, what is the cost associated with leaning on your organization to partner to do something like that?
That's I haven't costed this out in a while. The one that we're doing right now is extremely customized for an employer, and okay. So we're going well beyond the basic and looking at specific opportunities for them in the market. So it's a conversation we can have offline. It really just depends on the scale.
Yeah, I wasn't putting on the spot relative to, giving you exacts, but I think it'd be helpful to know if people are interested in the resource, can they even afford it? Because you're going to tell us it's $100,000. People can't afford that.
No, it's not. It's not $100,000.
I'm just making up a number, but you get my point, right? So if we have more clarity of, depending on the level of customization and sophistication you want, we have a range of, of how much it would cost. But I'm sure there are folks like us who work with these types of employers but don't have these internal resources to do the analytics, to be able to partner with CPR to give us some baseline understanding. It's not unlike what we do in international benefits. We'll work with an organization who specializes in understanding the laws and regulations of different countries, and then provide a country report to us to provide to our clients that when they want to expand into China or some other place in Europe, that they have a good understanding of what the market dynamics are before they actually operate their business.
Yep. Totally understand, and there's just a lot of variables in terms of the size of the market and all that, so let's just say we'll do it on a as-needed basis, and totally understand that people need to know that.
Great.
So, our long-term goal, as I kind of hinted at with the market assessment tool, is to have a better understanding of how market dynamics affect payment reform options and what payment reform options might work best in different markets. And, in a fantasy world, we would conduct these market assessments, let's say in the 75 biggest markets in the U.S. We would document what kind of payment reforms were happening there, and we would track the success of those payment reforms over time and really build our knowledge. We're not quite in a position to legislate that, to use legislation in a lowercase L kind of term. We're going to continue to sort of grow our learning in an organic way as demand comes to us and we have the opportunity to do it. But eventually, I think we do as a nation want to have a better understanding of what works where and why, and be able to replicate in a way that's very meaningful. So if you could say, this is market type 5 and so was St. Louis, and look what it worked in St. Louis, that could really provide some helpful guidance rather than everybody starting from scratch each time. So that's really what our goal is here, to develop more of an evidence base for what payment methods work best in each market type. But in the meantime, we hope we can be very helpful to the local stakeholders in helping them achieve a better understanding of what they're facing, what they're working with, and what their opportunities are, and how to avoid any unintended negative consequences. So with that, I believe I am turning it back over to Mark.
Yes, I'm going to just ask you a few questions that have been submitted. We don't have a tremendous amount of questions today, but we do have enough that we can certainly have a discussion about some of them. What are your perspectives, or do you agree or disagree that the ability of sophisticated integrated systems to more readily accept new payment forms is more likely due to their having more diversified payment dates and more cash in the bank to carry them while testing the new payment form? What are your thoughts?
Yeah, I think that the capital is really important, because in many cases, for providers to be willing to take on risk, they need a couple things. They need really sophisticated ways of tracking their performance in near real time, both from a quality and a financial perspective. And that's pretty hard to do if you don't have a solid health information technology system as well as other information systems set up. And then obviously, to be willing to take on risk, you've got to have the financial margin to be able to do that. And that's much harder for smaller shops than bigger, and that's part of why some people are saying the consolidation continues apace among providers, because it's very hard for them to anticipate being able to take these new forms of payment, given that, if they're small and don't have the infrastructure or the resources they need to be able to handle them. So I think, there's a positive and a negative side to all this reform effort, because, talk about unintended consequences. I don't think that those who designed the current health reform law were looking to create massive consolidation among healthcare providers, but that has been one of the impacts. I mean, it was already underway, but I think it has been accelerated by some of the reforms.
Yeah, I don't disagree. And one of the other questions we got was, how do any of the payment methods presented help reduce the actual cost of care to the consumer from your point of view?
Yeah, and that's a great general question, not necessarily to do with specific market dynamics. At the end of the day, the biggest challenge we have right now is that the single biggest driver of healthcare cost growth right now is price. So even if we create payment methods that create all the right incentives for providers to be more careful with our resources and to get healthcare done right the first time, and to reduce readmissions and reduce lengths of stay, and get people on medicines that can keep them from getting sicker and all that, if prices keep going up because consolidation allows prices to go up and providers to command higher prices, our cost trend's not going to look, it's not going to reflect any improvements in the delivery of care. And this is a huge challenge that we have. And this is why competition is so important, why making sure that employers and purchasers are savvy and, helping them in the ways that you guys can to find the best value. Keeping that pressure on for markets to deliver better value is going to be absolutely incredible, because, those prices can completely, drown any improvements we make on the efficiency side in terms of impacting healthcare costs.
Yeah, I think one of the things we didn't talk about that you might want to add to your analytic is, one of the best kept secrets, I think, in this entire discussion is the imbalance of reimbursement between public payer and private payer. So if you look at, on average, and, it's debatable depending on who you're talking to, but on average, Medicare and Medicaid is paying 61 cents for a provider saying it's $1. It costs $1. And in turn, the private market turns around and pays $1.39 to make up for what the federal government's not paying. So maybe when you're looking at different markets, you can also talk about the impact of public pay versus private pay, and ultimately the impact on public pay driving up the cost of private pay.
Well, the only thing I would say, Mark, is that those who are really geeky and get really into the data have found that in many cases this whole argument of cost shift is really not cost shifting, but it's price discrimination. And that providers will charge everybody the most that they can. And that's sort of natural economic behavior, right? And in markets where there's more competition, they have found that healthcare providers make a better margin on their public pay than they do in markets where there's less competition. And that's because they've had to get their cost structure under control to be able to survive in a market with more competition. In markets where they don't have to do that, then they cry and scream about how poorly they're paid. But it's frankly because, meaning by the public payers, and it's frankly because they just haven't worked as hard as they could to get their cost structure under control. So I just want people to kind of think broadly about that. Believe me, my members complain about cost shifting, but we've tried really hard to educate them about the fact that there's a lot more that healthcare providers could do to bring their cost structure under control, and we should keep that pressure on and not just feel bad for them.
Yeah, in a market where your own organization has scored our transparency at states across the country, and we have a failing grade. So in the absence of transparency and or a government structure like ours, where our Attorney General actually commissioned 3 reports on what's driving healthcare costs, and you're right, it is unit cost. It's price and it's brand strength of providers that are driving up costs, at least here in Massachusetts. How do we know if a provider is operating in an efficient way if you can't see the disparity of what they're charging for what they're doing?
Yeah, it's transparency is absolutely critical. And also, I mean, you were sort of raising before, sometimes there are very cozy relationships between payers and providers. And we need to keep the pressure on the payers to help provide more insight to their clients about what's going on under the hood.
Yeah, and you're saying cozy, and I agree. It's actually kind of an interesting thing. This is just a footnote, but the cross-pollination of boards between big payers and big providers is pretty startling when you take a look at it.
Mm-hmm.
You got payer people on health insurer boards and health insurer people on payer boards. So it seems like it's a little bit too cozy. That was just a little editorial on my part. What did the assessments of the 5 markets show? Can you share any of the results? More granular.
Yeah, gosh, I'm trying to remember now some really big takeaways. I think every market was different. To the point of the theme of today. As I said before, one common theme was that purchasers were really absent in shaping the market in all of the first 5 that we looked at. In some markets, there were some seeds of programs underway that we thought could really be built on. For example, in Minnesota, they are getting really into what's called total cost of care contracts, which we thought of as really a nice glide path to more bundled payment opportunities and global payment opportunities. In other markets, I'm just trying to remember back, there was a lot of, in Western Michigan, the Spectrum health system, was quite dominant, but Priority Health was doing some very interesting things, which is part of Spectrum, in transparency. And so we thought there might be an opportunity for reference pricing in that market since the providers are so dominant, but yet there was some pretty good transparency available. Employers could look into reference pricing, things like that. So, every market, again, different. And it really sometimes comes down to the individual players and some things that they've got going on that spark the ideas for what might make sense to try next.
Makes sense. So that's all the questions that we had submitted from our members today. I don't know if there's anything else you wanted to add before I gave some closing remarks from a broker perspective, but happy to give you the microphone.
No, the last thing I'll say is just to repeat that if people have feedback for me or are interested, feel free to get in touch. And thank you, Mark, for sharing this discussion with me today, and to NAHU for the opportunity to reach out to this audience and this information. I'm always humbled to do it because I know that everybody on the line knows more about their markets than I possibly could. But I'm hoping that by bringing some maybe systematic process to it, it can help open your eyes to stuff that maybe you might not have thought about.
And Suzanne, we appreciate your help, your support, and the work CPR is doing. And while you and I may not always come from the same place, I think we get to generally the same spot with regard to the fact that things do need to change, and we need to understand that, to our point today, that there across the country, and I think your organization taking a shot at trying to categorize those markets would be very helpful for us, for those of us that work with large multi-site employers who are really hungry for this type of information so that they can strategically plan appropriate. I think, as I mentioned in the beginning of our conversation, if you're working with self-funded multi-site employers, there are tools available for you to use to help you consult with that client and to develop a strategic plan that's unique to them and customized for them. Specific market data like key players, market share, concentration will help you assist in crafting a customized solution for your clients. And CPR does have a tool for market assessments, as you just highlighted for us. And I really appreciate the fact that you're approaching this with an open architecture. In other words, it's a technology term, but you're allowing us as people who are talking to the market come back to you to help refine that tool, and we certainly do appreciate it. I think from just a heads-up perspective, our 8th webinar in a series of 10 will be on Thursday, September 24th at 1 o'clock, and this is going to be talking about how to find out what value-based products insurers are offering to the market. So, Suzanne, again, on behalf of the NAHU Education Foundation and myself, thank you for the opportunity to continue doing this with you today, and for everybody, enjoy the rest of your day.
Yeah, thanks, Mark. Thanks, everyone.
Thank you very much, Ms. Delbanco, Mr. Gagna. We also thank each of you for participating in today's program. This concludes Webinar 7, How to Assess Your Local Market's Prospects for Payment Reform, presented by the National Association of Health Underwriters Education Foundation. Thank you again for attending. Have a great day, and you may now disconnect.